A lot can be said about pancreatitis, but I will just tell you about the most important things to know for the USMLE Step 2 CK. So the first thing is you need to know the difference between acute pancreatitis and chronic pancreatitis. Acute pancreatitis, acute abdominal pain, elevated lipase and amylase. CT shows pancreatic edema. And I want to emphasize that CT is not needed for the diagnosis of acute pancreatitis. CT is usually recommended if the patient continues to have worsening symptoms after 2 days of conservative management, or if there's a suspicion of cancer. The preferred initial imaging study in acute pancreatitis is a right upper quadrant ultrasound to look at the bile ducts and to see if there's any stones within the gallbladder. And then chronic pancreatitis presents as chronic abdominal pain, malabsorption symptoms, namely steatorrhea, weight loss, as well as diabetes, and the CT would show pancreatic calcifications. The second thing to know is to know the etiologies of acute pancreatitis. So if a patient, the two most common causes of acute pancreatitis are alcohol and gallstones. If the patient denies alcohol, then for the purposes of the boards, you got to believe the patient. It's not alcoholic pancreatitis unless there are lab abnormalities which are highly specific for alcoholism, such as elevated MCV, elevated GGT, and an AST greater than ALT. If the patient has gallstones or there is a dilated common bile duct, it's gallstone pancreatitis. If it's neither alcohol or gallstones, you should do a lipid panel to see if the patient has familial hypertriglyceridemia. And then if it's neither of these three, then you got to think about drugs. The most common are valproic acid, which is used in seizures or bipolar disorder, 6-MP, which is used in immunosuppression for transplants, and then DDI, which is a medication for HIV, which is not really used much anymore. There's also other medications as well, besides that can cause acute pancreatitis, such as thiazide diuretics, but those are uncommon. And then finally, the other one to know is trauma. You can have a pancreatic injury after a motorcycle accident, and you can get the similar epigastric pain, which radiates to the back. The third thing to know in this section is to know about how acute pancreatitis is graded in severity. And the most common score is the Ranson's criteria, and you don't have to memorize the Ranson's criteria. You just have to know that severity in acute pancreatitis is not related to the findings on the CT or the pancreatic enzyme levels, but what's actually happening to the patient. Is the patient showing signs of multi-organ failure? I mean, is there a base deficit? Is there third spacing? Is the hematocrit elevated? Is the calcium low? And hypocalcemia is an important one to know because it's specific to pancreatic necrosis. The calcium binds with the fatty acids to form soap, i.e. saponification, which happens in pancreatic necrosis. The management of acute pancreatitis, it's really just supportive care, and then it's cholecystectomy before discharge. And I want to emphasize this because this is per the AGA guidelines. Finally, you got to know about the complications of acute pancreatitis. Know that pseudocysts or infected fluid collections can occur, and endoscopic drainage is preferred rather than percutaneous or surgical, and drainage is only indicated when the patient is symptomatic. If the patient is not symptomatic, then these things can just be managed conservatively. So endoscopic drainage is preferred for pancreatic collections when the patient is symptomatic, i.e. if there's a gastric outlet obstruction. And then know about variceal bleeding from after acute pancreatitis, and that happens as a result of splenic vein thrombosis. And I promise the final thing is treatment of chronic pancreatitis. Chronic pancreatitis results in, most commonly due to alcohol, results in destruction of the pancreatic parenchyma and pancreatic calcifications. This leads to destruction of the islet cells which produces insulin, and you get diabetes. And the treatment for diabetes secondary to chronic pancreatitis is insulin. It's never sulfonylureas or other oral agents. They're missing insulin, so they need insulin supplementation if they have diabetes. And if they have malabsorption, i.e. steatorrhea, diarrhea, weight loss, then they need pancreatic enzymes. They don't need anything else to treat the diarrhea. If you're struggling with the Step 2C case studying and want to discuss strategy and speak to an actual human being, please email me at dr.k@medexamcoach.com, dr.k at medexamcoach.com. I have a free 500 question knowledge builder quiz link in the description below, or you can copy this link if that link is not active. And any feedback or comments is appreciated for future topics. Thank you.